I strongly believe that surgical embolectomy in pulmonary embolism mostly is not the right way to go because you have an already strained heart, especially the right heart. And when you open the pericardium, there's a lot of evidence from the 90s, late 80s that you produce a long-term right ventricular dysfunction on the one hand. On the other hand, you create a large wound surface, and these patients already have coagulation problems, especially when fibrinolytics have been used, and you have to operate them when you're on cardiopulmonary bypass on full heparinization. So you might, and you always do have, and there's some data on that, severe bleeding afterwards. So we have two components, and I think the most important is right ventricular dysfunction after cardiac surgery. Of course, when you use a closed chest approach like the ECOS catheters, you do not open the pericardium, so you do not decrease right ventricular systolic function. And of course, we still have to do some studies on that, but this is our belief that surgery, even as surgeons, is not the right way to treat pulmonary embolism. It changed the whole thing, not even in our department, but in the whole hospital, because 2 years ago, before we started the whole PERT and the ECHOS program, only patients in hemodynamic shock or on the verge of dying actually were presented to us. So all the intermediate high-risk patients, we'd never seen them, they were never presented to us. So now we have an interdisciplinary team where each patient is discussed, so we have more shoulders to underline the decision of therapy, which makes life a bit easier. And we have almost stopped operating on patients with pulmonary embolism, which is quite sad because it's a nice operation. And the mortality rates are quite low, but again, it is much more invasive than putting in a catheter or two. The team is comprised of cardiac surgeons and cardiologists. We do have radiologists and anesthetists as well, and the ER people. So most patients are admitted to our hospital by ER. On the other hand, there are more and more increasing numbers of patients being presented from other hospitals in our area. And we look at the biomarkers, we look at hemodynamics, we look at the clinic of the patient's symptoms, and of course the CT scan and the echogram. And together we decide, do we need more than heparin? And if so, what sort of treatment is needed? So if we have patients with a high-risk pulmonary embolism, we look at their hemodynamic stability using echocardiography, looking at their stroke volume index. If that's below 35 milliliters per square meter body surface area, and you need vasopressor inotropes, we nowadays decide to put in an extracorporeal life support before we start the ECHOS therapy. That's a very good question because that's a very dire scenario when you have had large surgery, non-cardiac surgery, abdominal or even intracranial surgery, and patients have massive pulmonary embolism on their first post-operative day, which happens more than you think. And to date, we would operate these patients, of course, with cardiopulmonary bypass and full heparinization, and we would have massive bleeding complications, especially with intracranial patients. So after the preliminary results of Optimize were presented, we did a paradigm shift and used ECOS catheters with a very low dose regimen to treat these patients. We had patients with neurosurgery, patients with large abdominal surgery, and facial surgery, and even cardiac surgery. And we used the very low dose, and for a very short period of time, the ECOS catheters with quite good results and no major bleeding complications, which surprises, I have to say. The current guidelines from 2015 still suggest that heparin alone is the way to go in pulmonary embolism. It doesn't matter if it's intermediate low or high risk. Massive pulmonary embolism is something different. I'm not going to go into that now. But to almost persuade the colleagues to rethink their therapy concept in pulmonary embolism was very hard. In our own hospital and in all the hospitals around in our area, which are a lot, the physicians, especially elderly physicians, would always say, we have used heparin alone in pulmonary embolism with good results, and we're happy to do so in the future. We do not understand and we do not follow your therapeutic concept for pulmonary embolism. After showing them the current studies and using their common sense of physiology, they do understand why heparin alone is not enough in pulmonary embolism intermediate high-risk patients. But that was a very hard process to really get the word out.